Fetal heart rate monitoring. This mini lecture is going to discuss some of the basic terminology and what we look at when we do fetal heart rate monitoring. And then we'll get more in depth in class about the different ways we go about that, implications for what we see in fetal heart rate monitoring. So we're going to start with just the basics. So what do we look at when we put a baby on the monitor? So we're looking at two different things. We're looking at the fetal heart rate, and then we're looking at the contraction pattern. So the cardiac activity of the fetus and the uterine activity of its environment. So when we look at the fetal heart rate, we are looking specifically at four categories: the fetal heart rate baseline, the variability of the fetal heart rate, and then for any accelerations or decelerations in the fetal heart rate. And when we look at the contraction pattern, we are looking to see three things: frequency, duration, and strength. So for example, when you look at a fetal heart rate monitoring strip that's printed on a piece of paper, whether it be from an internal monitor or an external monitor, any continuous fetal monitoring is going to print out a strip that looks like this. And it might be different colors. It may be using different pieces of equipment, but the fetal heart rate is always going to be on the top, and the contraction pattern is always going to print on the bottom. Okay, that's universal. So that fetal heart rate, when we talk about the baseline, think of the baseline as an average. If you were looking at the fetal heart rate printout and you wanted to draw an imaginary line through the fetal heart rate that would hit the most points, so the average, and we round that to the nearest 5 when we're doing continuous monitoring. So it's never going to be baby's fetal heart rate baseline is 143. We would say 145. We want that baseline to fall between 110 and 160. That is our normal. We look at least a 10-minute strip to determine a baseline. We want an average over 10 minutes, and we exclude any periodic changes. So if we have accelerations or decelerations, we don't calculate those into our baseline. We'll talk about what those look like here in a minute. So it's an average over a 10-minute period, and we round that to the nearest 5. Variability is the beat-to-beat changes in fetal heart rate. Unlike an adult or an older child, the fetus changes its heart rate very frequently to respond to changes in the blood volume it's receiving and the oxygenation of the blood it's receiving. So baby's heart rate changes very frequently. It looks very jagged when it's printed out on paper. It's not a smooth line. And we'll talk about why that's so important in class. Accelerations and decelerations are pretty self-explanatory. So an acceleration is an increase, a periodic increase in the fetal heart rate, and a deceleration would be a periodic decrease in the fetal heart rate. We have certain minimum requirements for accelerations, and then we have different categories of decelerations. And what category it falls into tells us what the cause of the deceleration is. When we are describing the contraction pattern, frequency is the start of one contraction to the start of the next contraction. Usually that's described in a matter of minutes. It doesn't have to be even. So we don't always have, contractions are every 3 minutes exactly. Sometimes it's every 1.5 to 3 minutes. Sometimes it's every 60 to 90 seconds. So it's very common for that to be a range. Duration is the start of the contraction to the end of the contraction. Usually this is described in seconds. So we might have 50 to 70 seconds. Again, it's a range because not all contractions are completely even in the duration. So it's usually a range in seconds. And then the strength of contractions corresponds to being mild contractions, moderate contractions, or strong contractions. We can only tell realistically the strength of contraction by using an internal contraction monitor, an IUPC, that stands for intrauterine pressure catheter, or palpation, using our hands on the woman's abdomen to palpate the strength. Now, if you can think of putting your hands on a pregnant woman's abdomen to palpate the strength of a contraction, if you take your finger and push on the end of your nose, the tip of your nose. We have some firmness, but it's still squishy, right? You can feel. That would be resembling a mild contraction strength of the abdomen. You take your finger and push on your chin. So we've lost some squishy, it's more firm underneath the skin. That would be reflective of a moderate contraction. And then if you push on your forehead, the thinness of that skin and the very firmness underneath, that would be reflective of a strong contraction. Okay, so mild, moderate, or strong. We can run the risk of too many contractions too close together. Another important piece of assessing contractions is to assess for the resting tone in between contractions. We want mom to have a period of rest between contractions. Not only does that allow for rest of mom because contractions are stressful, we also want that relaxation for baby. Between contractions, when the uterine muscle is relaxed, is when we get all of that blood flow back and forth, taking oxygen to baby, pulling away carbon dioxide and waste. So that rest period in between contractions is important to build up baby's reserve. So we have a term, tachysystole. Uterine tachysystole would be more than 5 contractions in a 10-minute period. So if we say most of the time, especially once we get to that active phase of labor, that contractions last 60 seconds or more. If we are in a 10-minute period and we have more than 5 contractions, so let's say 6 contractions, and they're all lasting at minimum 1 minute, we have already decreased our rest in that 10-minute period to at most 4 minutes of rest. So if we get to the point where we have uterine tachysystole, most times that is induced by external factors. So whether we have mom on Pitocin that we're inducing those contractions, or she has an extra strong reaction to Cervidil or Cytotec when we've augmented labor. Those kind of pieces we get very, very cautious about because that can decrease our baby's reserve and compensation very quickly. So we talk about changes in fetal heart rate being periodic or episodic. And that has to do with whether the changes, those accelerations and decelerations, are in line with contractions or they happen irregardless of contractions. Another important piece to monitoring contractions is that our external methods a lot of times don't pick up contractions as accurately as they are happening. So we go very strongly off mom's report of pain and contractions because she is our best source of data for that. The baseline, we talked about we want to be in between 110 to 160. If we have a baseline above or below that average range, we would consider that tachycardic or bradycardic. And we have some specific influences we know that are to increase the likelihood of our fetal heart rate being tachycardic or bradycardic. Variability, we have multiple levels for. So we have absent, minimal, moderate, and marked. We're going to talk about those 4 categories in class. And then accelerations, we just have whether they're accels or not. And then decelerations, we have variable decelerations, not to be confused with variability, variable decelerations, early decelerations, and late decelerations. So we're going to talk about all those categories in class, but that gives you a basic understanding of the terminology of what we are looking for with fetal heart rate monitoring.